Assalamu alaikum. My name is Jenan, and in this video we will be covering the lymphatic system and the lymphoid organs and tissues, which is chapter 20. And then hopefully I'll be covering the first part of the immune system chapter, and then Umar will be covering the rest of it. So first of all, to begin, it's very important to note that the lymphatic system is different from the lymphoid organs and tissues. Even though they're considered as one chapter for you guys, they are quite different from one another and they function in different aspects. The lymphatic system, the main job or the chief point of the lymphatic system is that sometimes we have, or most of the time, when we have the exchange of blood and fluid in the capillaries, some of the fluid that is going to return back to the veins is going to remain in the interstitial compartment. So the job of the lymphatic system is to return this leaked fluid back to the vascular system, and we'll understand why in a bit more details. But for the most part, it constitutes of the lymphatic vessels, lymph, and the lymph nodes. On the other hand, the lymphoid organs and tissues are mainly what constitute or what forms the immune system, which is the system in our body that is mainly concerned in fighting against pathogens or disease-causing microorganisms. It has a lot of different organs, including the spleen, the thymus, tonsils, lymph nodes, and other tissues and other organs. Now, for the most part, as you can see, the lymph node is both part of the organs and the tissues, which is constituting the immune system, and part of the lymphatic system. So let's start by looking at the lymphatic system. Again, to put it in very simple words, the point of the lymphatic system is sometimes, or not sometimes, all of the times, what happens is you have in the capillary beds, we have an arterial side and a venous side. The arterial side, due to hydrostatic osmotic pressure, fluid will leave and go into the interstitial compartment. It becomes interstitial fluid. It goes outside, and then it will supply the tissues in that region or the cells in that region. Then what's supposed to happen is because of the colloid osmotic pressure, the veins will pull back the fluid inside the venous side. So again, in the capillary bed, I have a arterial side and a venous side. The arterial side will push the fluid outside, whereas in the venous side, because of the main reason that it will pull is because we have the non-diffusible molecules, so like proteins and so on. These structures, they will pull back the water inside to balance the solute and solvent concentration. Now, some of this fluid that is going to come from the arterial part isn't going to go back to the venous part. And this fluid remains in the interstitial fluid, and it's around 3 liters. So the job of the lymphatic system is to return back that fluid that didn't go back in the venous part, or to the venous side of the capillary bed. So hydrostatic osmotic pressure will push the fluid out at the arterial end of the capillaries, whereas colloid osmotic pressure will pull them back inwards because of the non-diffusible molecules. And most of the fluid is reabsorbed. Most of the fluid will go back to the veins, but there is around 3 liters every single day that will remain part of the interstitial fluid. So the point of this lymphatic system, the reason we need the lymphatic system, is for it to return this protein-containing interstitial fluid, to return it back to the vascular system so that the heart has enough blood volume to pump to the rest of the body. So these drainage vessels that we will talk about, their whole job is that they're very leaky and very, very permeable, and they allow for the lymph or the interstitial fluid to enter inside them and ultimately return them back to the heart. So this interstitial fluid that was here, that was leaked and didn't come back, these lymphatic vessels and these lymphatic capillaries will pull them back upwards. And when this interstitial fluid, or when this fluid, protein-containing fluid, enters inside the lymphatic capillaries, we call it lymph. So the drainage vessels capable of this is known as the lymphatic vessels. They will pick up the interstitial fluid and they change the name, becomes lymph, and it will return it to the bloodstream. So when it comes to the general schematic of the lymphatic system, it starts off as lymphatic capillaries, which are going to basically be located in between the capillary beds. Then we will have them going into uniting as lymphatic vessels, then lymphatic trunk and lymphatic duct. And we sometimes have the lymph node, where basically the lymph can stop there, it can get cleansed. The whole point of the lymph node, which we'll talk about later on, the whole point of the lymph node is to cleanse of any pathogen or disease-causing microorganism. It's a point where the lymph can stop, and basically we can activate the immune system if need be it. But let's start by looking at the lymphatic capillaries. So the lymphatic capillaries are these very small microscopic capillaries that are going to basically be present between your normal blood capillaries, and they are pretty much widespread and found everywhere in the bodies except in the bones and the teeth. They used to think that before it wasn't found in the CNS, but it's actually, it is found, but in restricted areas in the meninges and so on. But for the most part, it is found everywhere in our body. Now, what gives us the property that it can, be able to pick up the fluid and pick up all of these, pick up the interstitial fluid? What allows it to do that? It's mainly the way that the endothelial cells, or the cell that will form its wall, the way that it is formed or the way that it is presented is the fact that these endothelial cells aren't tightly joined by one another. They're not, sitting on one another and tightly joined to one another. Instead, they're just overlapping. You can see here in the picture, they're overlapping over one another. They're not tightly joined to one another. So this forms mini valves. So again, the capillaries, the lymphatic capillaries, the endothelial cells that will form them are not tightly joined to one another, and they're not tightly, binding to one another. Instead, they're just sitting on top of one another loosely, and ultimately this forms mini valves. Now, the reason that they open and close and accommodate fluids entering in and shut when there's fluid inside is due to collagen filaments. These collagen filaments are going to anchor the endothelial cells on certain structures around them. So what happens is when the volume of the interstitial fluid outside is higher, it will pry them open. So it will open these endothelial cells when the fluid outside is greater, and it allows the fluid to enter inside. But when the fluid volume inside the capillaries is greater, it forces these valves to close shut so that the fluid doesn't leak outside. So again, the reason that these lymphatic capillaries, which are the beginning of the lymphatic system, these capillaries that are present between the blood capillaries that will pick the leaked fluid and make it be part of the lymph and basically allow it to get returned back to the blood circulation. The reason that it is capable of doing that is mainly because of its mini valves. The cells are not tightly joined to one another, but they are sitting on top of one another. And due to change in the fluid volume outside or inside the capillaries, they open and close because of the collagen filaments. If the fluid volume is greater in the interstitial compartment or outside the capillary, this will pry them open and allows the fluid to enter inside, along with proteins, because the lymphatic capillaries are a lot more permeable than your normal blood capillaries. When they open, the fluid along with the protein enters inside, and this allows it to go up in the system. But if the fluid inside is already present and it is high volume, what happens is these lymph valves, these flap-like mini valves, are going to close shut, so it doesn't allow them to leak back upwards. Another thing worth mentioning is that, as we said, in the middle, we can stop sometimes the lymph fluid, or the lymph is going to get basically drained or cleansed by the lymph node. What happens is during inflammations or during infections, when the body is infected with microorganisms and pathogens, what happens is these capillaries, they become more permeable, so they allow to pick up more debris and more pathogens and so on. Something worth mentioning with regards to the lymphatic capillaries is that we have a specialized type of lymphatic capillaries called lacteals. These lacteals are pretty much nothing, just capillaries that are going to pick up milky white fatty lymph, and we call this specific type of lymph as chyle. Again, lymph is the interstitial fluid that was leaking outside that was put inside the lymph capillaries. We call it lymph. A specific type of it is fatty in type and white in color, and we call it chyle. And these lacteals, their main job is to pick up this chyle from the small intestine, return it back to the bloodstream. And it will drain this lymph, or this chyle is going to drain from the villi of the intestinal mucosa. So it's just a specialized type of capillaries that is going to pick up the chyle from the small intestine and drain it back to the bloodstream. So this was everything regarding the lymphatic capillaries, these small capillaries that are going to interweave their way or find their way between the blood capillaries and pick up that fluid. Now we need the fluid to return back to the circulation, to the venous circulation. How does that happen? It goes to the collecting lymphatic vessels, then the lymphatic trunk, and then finally we reach the ducts. The lymphatic vessels are very similar in structure, specifically with their tunicles or their layers when it comes to veins, but in general they have thinner walls, more internal valves, and and they have more anastomosis. Anastomosis is just the connection, so they are more connected and more branching, and they start connecting with one another more than what we see in veins. So they're just vessels that are going to be the continuation of the capillaries. In general, they travel superficially and deeply. The ones that are present in the skin, the lymphatic vessels that are present in the skin, are going to travel along with these superficial veins. But the ones that are present deeper in the trunk and present in the internal, digestive viscera and so on, are going to travel with the deep arteries. But the exact distribution of them, the exact anatomical positioning of them, varies greatly from one individual to another. But what is commonly known is that the ones that are present in the skin, the more superficial one, are moving with the superficial vein, and the deeper one is moving with the deep arteries. So this is with regards to the collecting lymphatic vessels. These vessels are then going to unite to form trunks. Trunks are basically the part that will drain large areas of the body. And for the most part, we have the paired lumbar trunk, paired bronchomediastinal trunk, subclavian, and jugular. The only one that we will have it in singular is the intestinal trunk, which is going to drain your digestive organs. Finally, everything is going to drain in one of the two trunks, either the right lymphatic, one of the two ducts, either the right lymphatic duct or the larger one, which is the thoracic duct. The right lymphatic duct is going to drain the right upper limb, the right side of the head, and the right thorax or the right chest. The larger thoracic duct is going to drain everything else, the rest of the body. So let's look at it in a schematic or in a diagram. So as we said, we start off with capillaries, which are these structures that are going to be interweaving and finding their way between the blood capillaries. Then they go upwards as vessels, and then these vessels are going to continue as trunks, and then finally we have ducts. So let's look at mainly focusing on the trunks and the ducts. We have the trunks. We said we have paired lumbar, so right and left lumbar trunk. Then we have paired bronchomediastinal trunk, paired subclavian and paired jugular trunks, and a single intestinal trunk. Then we have two ducts, a right lymphatic duct and the thoracic duct. The right lymphatic duct is going to drain the right side, the upper right side, the right upper limb, which is the arm, and the right side of the head and the thorax or the chest region. Then we will have the thoracic duct emptying the rest of the body. Sometimes in some individuals, the thoracic duct begins as something called cisterna, which is essentially just an enlarged sac that is present in the lower part of the back, between like the lower thoracic and the upper lumbar region of the vertebra. We have just an enlarged sac that we call it as cisterna, which is nothing but the beginning of the thoracic duct. So, again, you can see very simply how they will drain. So the right side, the right upper side is going to drain in the right lymphatic duct. But for instance, the intestinal trunk, which is basically the intestinal organ, the digestive organs, are going to drain in the thoracic duct, along with the lumbars, the right and left lumbar, which will drain the lower limbs, and so on and so forth. They're all going to drain in the thoracic duct. Both the ducts are going to drain between the subclavian and the jugular vein of the respected site. So between the subclavian and the internal jugular vein of their site, to return back the fluid into the venous supply or the venous circulation. So ultimately, this is how we have the entire pathway or the entire system working, or the circulation working, to return back this leaked fluid back into the vascular system. Now, the way that these fluid is going to be pumped back up, it's very important to know that these vessels are low pressure conduits. They work very similar to the way that veins are going to return the blood supply back to the heart. Some of the ways that we have is the skeletal muscles that is going to contract around it and then return it back upwards. Also, when the person is breathing, there is a change in the chest or the thoracic region. Ultimately, this can help bring back. We also have valves that will prevent backflow of the fluid or the lymph, so it prevents it from going back downwards. We also have the fact that these lymphatic vessels or these lymphatic capillaries are going to basically, or many of the vessels, are going to be present near arteries and near connective tissue sheaths. So ultimately, when the arteries are pulsating and contracting to bring the blood to specific organs, this helps the lymph return backwards. And pretty much all of the lymph vessels, except the very small ones, there is smooth muscles which can contract and help in returning them. So mainly it's just a combination of different structures like the valves, skeletal muscles, arteries, and so on that will help return the fluid back upwards. In general, the movement of it is quite slow, which is ideal because we want the body to be able to allow the lymph to sit in the lymph node and be checked if there is anything that needs to be removed. But during physical activity, the lymph will start moving a lot quicker and a lot more rapidly and ultimately this might result in imbalances, fluid loss, and so on. So normally if a person is badly infected, it is important to immobilize the body so that the fluid or the lymph can move very slowly. So now with regards to the homeostatic imbalances in the lymphatic system, there are two main things to mention: the lymphangitis and lymphedema. Normally, when we have an inflammation and we have a site that has inflammation, the blood vessels around that area becomes dilated, and we'll understand that more in the immune system. But one of the hallmarks of inflammation is redness in that area. Again, when the lymphatic system or any region in our body becomes inflamed, the blood supply becomes dilated to allow more blood to come in that area, carrying more of the protective cells like the white blood cells and so on. So what happens is if the lymphatics become inflamed, the supply around them, the large lymphatics, they receive their blood supply by a branching anastomosis and branching blood supply called vasovasorum. So when these lymphatic vessels become inflamed, these vasovasorum become congested with blood. They become dilated and they have a lot of blood in them. So what happens is along these superficial lymphatics, which we said they're going to run along with the superficial veins, this blood supply becomes congested with blood, so you can see it as red streaks. So because they're inflamed, the blood supply around them becomes congested. So the superficial lymphatics, when they become inflamed, they appear as visible red streaks that are tender or painful to the touch. And this is what we call lymphangitis. Lymphangitis is inflammation of the lymphatics. And when these lymphatic vessels are going to be inflamed, the blood supply around it is going to be congested with blood. Ultimately, this will result it to appear as red streaks on the skin, as evident by this picture. Lymphedema is just basically an abnormality due to a tumor blocking it or whatever, where basically it limits or inhibits the return of the lymph back to the blood. So there is edema or swelling in the specific region. So it's called lymphedema. So just to go over everything regarding the lymphatic system, it is basically a system that works in basically to prevent any abnormalities in the fluid volume. So in the arterial part, the hydrostatic osmotic pressure will send fluid outside, and then the colloid osmotic pressure will pull that fluid back inwards in the venous return or in the venous part. And some of that fluid will remain in the interstitial fluid, around 3 liters every single day. So the lymphatic capillaries, because of their valves, because of their collagen filaments or their collagen parts, they will pry the mini valves open, allowing for the fluid to sit inside the capillaries. Then the capillaries will continue as vessels, which, we said they're very similar to veins. They have the same layers, but the anastomose more, they have thinner walls. The superficial ones will run along with the superficial veins, but the deeper one run with the deep arteries. Then they go to the lymphatic trunks. We have the paired lymphatic trunks, the lumbar, bronchomediastinal, subclavian, jugular, and then the single intestinal. And then finally they empty into the ducts, and the ducts will empty between the subclavian and the internal jugular veins. The ducts, mainly the right lymphatic duct, and finally the thoracic duct, which is on the left side, the bigger one that will drain the majority of them. We do have specialized lymphatic capillaries like the lacteals that we mentioned, that's mainly going to drain the fats and the white chyle lymph. And we said this lymph node is a very important stopping point because it can check the lymph for any pathogens and activate the immune system to alert it for this abnormality. So the whole job of the lymphatic system or the lymphatic vessels is to return this excess fluid back to the heart or back to the venous system, as you can see here. Return the leaked proteins, carry pathogens to the lymph node, and we'll understand why exactly is it the lymph node. Carry pathogens, as we said, to the lymph node, and carry any absorbed fat from the... Now, with regards to the lymphoid organs and tissues, we will start off by looking at the cells, the tissues, and then we'll build up our way to look at the main organs that we see in the system. Again, as mentioned in the beginning, the main role of the system is to help in the immune system, to help with immune surveillance, and to help keep our body capable to fight against antigen and provide the body with what we know as immunity. Starting off by the cells, most of these cells are going to be mentioned again in the immune chapter. But the key role players when it comes to our immunity are our lymphocytes. Before talking about lymphocytes, to give a quick and general introduction about the immune system, our immune system is comprised of 2 arms. It has an adaptive and an innate arm. The adaptive arm is the arm that needs longer time to get activated because for the most part it's the arm that needs something we call as antigen presentation. So what exactly is the antigen? The antigen is essentially almost like a protein that's present on the surface of most of our body cells and certain pathogens that when presented to lymphocytes or when presented to our cells, specifically these lymphocytes, they are going to understand, is this something foreign? So do I need to get rid of it? Or is it normal? Is it my self antigens and I need it to be maintained in the body? On the other hand, the innate arm or the innate immune system doesn't really care much for antigens. It's not very specialized or not very specific. That's mainly the part of the adaptive immunity. So the adaptive immunity is what constitutes or what's formed of these lymphocytes, the T and B lymphocytes. Upon presentation of antigens by certain cells like macrophages and dendritic cells, these cells are going to get activated, T and B cells, that have different functions and work in different ways. For the most part, B cells, they release a subset of cells called plasma cells, and these plasma cells will release antibodies, and antibodies have a number of different functions that they will do that we will be discussing later on in the adaptive immunity in the immune chapter. On the other hand, when T cells are activated, T cells themselves have different subsets. They have cytotoxic T cells, helper T cells, regulatory T cells with different functions, each one fighting against a specific pathogen, fighting against a specific infection. But again, the whole point or the whole idea to mention is the fact that lymphocytes, which constitute the second arm of the immune system, needs antigen presentation. It needs the antigen to be presented to it to get activated. Antigen presentation is done by cells called APCs, or antigen presenting cells. These include macrophages and dendritic cells and another cell, but that will be discussed later on. So macrophages and dendritic cells are also called lymphoid cells. They are antigen presenting cells and they will activate T cells and sometimes even B cells. But macrophages, what distinguishes them is the fact that they are phagocytic cells, and we'll mention phagocytizing and what exactly that means in the innate immunity. Then the last thing that we have is these reticular cells. The reticular cells are very important in producing or forming the reticular fiber stroma, which is essentially the stroma that is present in all of the lymphoid organs minus the thymus, or excluding the thymus, and we'll understand why exactly what the thymus has and what is the stroma of the thymus. So again, lymphoid cells are the cells that are essentially their immune cells. They include lymphocytes, T and B cells forming the adaptive immunity that have different ways. The B cell is humoral immunity, whereas the T cell is cellular immunity. But for the most part, when the antigen is presented to them, they're activated and they protect the body against them. Macrophages and dendritic cells are both APCs, and they can activate the adaptive immunity. Macrophages and dendritic cells are part of the innate immunity that will then go and activate the adaptive immunity. And macrophages have the phagocytic ability. And finally, the reticular cell, which is the cell that can produce the reticular fiber stroma, which is basically the network of fibers that is pretty much seen in all of our lymphoid organs, excluding the reticular fiber stroma is not present in the epithelial cells. The lymphoid tissue, so that was regarding the tissue, the cells. The lymphoid tissue is basically the tissue that will form the organs, that is very important in housing the lymphocytes or cells and allowing them to be activating and proliferating and multiplying in number, and also provides a very important point or part for surveillance, immune surveillance, which is basically the point in which the lymphocytes can sit and reside and wait for antigens to be presented to them and get activated, for lymphocytes and for macrophages. So as we said, we previously mentioned, we have the reticular cells. They will form the reticular fiber stroma, and this reticular connective tissue is basically the loose connective tissue that will form the lymphoid tissue, which is present everywhere in all of the organs, excluding the thymus. So this reticular connective tissue is very important. It's because it allows macrophages to live on the fibers or to sit on these reticular connective tissue fibers, and allows them to be easily accessible to the pathogens to phagocytize them. Something also worth mentioning when it comes to lymphocytes is their continuous circulation. They're continuously going between circulatory vessels, lymphoid tissue, loose connective tissue in the body, and so on, to ensure that they are well capable and well aware of everything that's happening around the body. So these are the lymphoid cells and the lymphoid tissue. The lymphoid tissues in our body, they present in two main ways. They come in different packages and they come in different ways, and they present as two main types. They present as a diffuse lymphoid tissue, and they present as lymphoid follicles or lymphoid nodules. The diffuse lymphoid tissue, as the name suggests, they're not really compact, they're diffuse. They're loose arrangement of the cells, there's some reticular fibers, and so on. They're pretty much found almost everywhere in every single organ, and they're just essentially like a collection or a loose arrangement of these lymphoid cells. Unlike the lymphoid follicles or the lymphoid nodules, which are actual solid and spherical bodies that are having tight, packed lymphoid cells. So they're lymphoid follicles. They are basically bodies of tightly packed lymphoid cells and reticular fibers that are going to be found in certain organs, or they can be found as aggregations isolated alone. Now, for the most part, these follicles or these nodules have a center, we call it a germinal center, which is constituting of B cells. It's a lighter staining germinal center where we have these B cells situated and located. If these B cells are highly proliferative, highly differentiating, highly dividing, then this center will increase in size. But again, the lymphoid tissues present in two main manners. They can either be diffuse, a loose arrangement that is present in some organs and some sites in our body, or it could be lymphoid follicle or lymphoid nodule, which is a solid and dense spherical body that has lymphoid cells tightly packed. And in the center, we have a lightly staining region. We call it germinal center, which is constituting of B cells that are highly proliferating and dividing. Sometimes these lymphoid follicles can either be found as part of a larger organ, like in the case of the lymph node, which we'll discuss next. So they're not alone, they're not present isolated, they are present as part of an organ, a larger organ, or they can actually be present as an isolated aggregation of lymphoid follicle. And this is like in the case of the Peyer's patch, which is the mucosa-associated lymphoid tissue. We have something called Peyer's patches, which is present in the small intestine, and also we have in the appendix, which is in the large intestine. Again, they're just the idea that these lymphoid follicles can be present as part of a larger lymphoid organ, or they can be present as aggregations and isolated and considered their own structures. Now let's start by looking at the lymphoid organs. How can we group lymphoid organs? So we spoke about the cells, the lymphocytes, macrophages, reticular cells, and the dendritic cells, and we spoke about the tissue, the arrangement of it, the fact that it allows for a surveillance point, it allows for lymphocytes to proliferate and divide and so on. And then we said we have two main different types, the diffuse and the nodules or the follicles. Now, when it comes to these lymphoid organs, which are mainly going to be constituting of these tissues and cells, we have primary and secondary lymphoid organs. The primary lymphoid organs are essentially your red bone marrow and the thymus. The red bone marrow is the site where you will have the B and T cells formation. The B and T cells, during the production of blood cells, this happens in the red bone marrow as discussed in the blood chapter. On the other hand, I have these immature T cells and immature B cells. To get them matured, or what we call as immunocompetent, the T cells are going to go to the thymus. B cells will remain in the bone marrow. So they become mature in different sites. They are all going to be produced in the bone marrow, but B cells will remain in the bone marrow and T cells will go to the thymus. So these are the primary lymphoid organs. It's the site where we will have the maturation. These cells are still not yet to encounter a pathogen. They're not ready to encounter a pathogen. They will only encounter a pathogen in secondary lymphoid organs. And we'll talk about the thymus more towards the end. But secondary lymphoid organs are the sites like the lymph nodes, the spleen, MALT, and so on. These are the sites that will allow antigens or lymph, and we'll talk about the difference between that, to be presented to these T and B cells to allow them to get activated and then be able to fight against them. So a mature B and T cell doesn't mean it's ready to encounter, doesn't mean it's ready to fight against it. It will only be ready to fight a pathogen once it has encountered its antigen, which is in the secondary lymphoid organ. So in the primary lymphoid organ, the main point of these organs is to mature them, to make them immunocompetent, to give them the certain receptors needed to identify, because B and T cells are specific. Each cell is specific to a certain antigen or to a specific protein on a specific pathogen. You will not find one T cell or multiple T cells having the same receptor or the same specificity. Every single cell has its own receptor. This education and this level of formation happens in the primary lymphoid organs, the bone marrow, the red bone marrow for the B cells, and the thymus for the T cells. But actually encountering the encountering the pathogen is what happens in the secondary lymphoid organs, and this is the site at which the cells become capable of fighting against the disease or fighting against the pathogen or the infection. Now, for the most part, all of these organs are important to help protect the body against diseases. The dendritic cells or the macrophages, the APCs, they can pick up any pathogen or any antigen and then go and present it, be it in the lymph node, be it in the spleen, be it in the MALT, and then allow these cells to get activated and so encounter a pathogen. But the only one that will actually allow for cleansing of the lymph and the fluid is the lymph node. And as we've mentioned, the lymph is the one that will be present after the lymphatic vessels, before they go to the trunks and before they go to the ducts. We will have these lymph nodes that will allow for cleansing of the lymph, because they're the only organs that have both afferent coming and efferent leaving lymphatic vessels. Other ones, they would only have efferent draining them, but they lack afferent lymphatics. So that's just an important thing to mention in the secondary lymphoid organs, that they are all in general important in getting rid of infections and getting rid of pathogens and protecting the body. But the lymph node is the only one that will cleanse the lymph, because it has both afferent and efferent fibers. So this is regarding the primary and secondary lymphoid organs. Now, moving on, we can look at each and every single organ. We'll discuss the lymph nodes, we'll discuss the spleen, the mucosa-associated lymphoid tissue, and finally we'll discuss the primary lymph organ, and we'll discuss about the thymus only because the bone marrow was previously discussed. So the lymph node is basically a cluster that they're just clusters of these organs. They're lymphoid organs that are called lymph nodes. They cluster around certain structures, the lymphatic vessels that we mentioned previously. So we have lymphatic capillaries and lymphatic vessels. Lymph nodes, which are these organs, these secondary lymphoid organs, they cluster mainly around these lymphatic vessels, these collecting lymphatic vessels. We will have aggregations and collections of these nodes. For the most part, they're not really ordinarily visible. They're normally present embedded in connective tissue, so they're not actually present visibly. But for the most part, they're present mainly, like the larger clusters and the larger groups are present in sites where we will have the formation of the trunks. So where we have formation of the trunks, be it the intestinal trunk or whatever, the lumbar trunks and so on. Where we have these formation, this is where we have the majority of the large cluster. We have inguinal, axillary, and cervical. Inguinal, axillary, and cervical, those are your largest or the biggest kind of clusters that we have of lymph nodes. What exactly is the function of the lymph node? What is the role of the lymph node? It's, as we mentioned, it cleanses the lymph. It will allow the afferent fiber to bring in the lymph, and then the efferent fibers will drain the lymph, and inside the lymph node we will have certain macrophages sitting on reticular fibers that will get rid of these pathogens and so on. And other than that, we also have the activation. So not only can it accommodate for the lymph, but it also helps in, if a dendritic cells comes carrying an antigen, it can activate some of these B and T cells that are present inside the lymph node and allow them to fight against pathogens. So it will activate the adaptive immunity via different dendritic cells or via these different APCs that we have present, and allows them to be activated and fighting against pathogens. So again, the lymph node is mainly the site that we have the lymph coming and cleansed, and also for immune activation. Now, how is it, if we're looking at it in the structure, how does it exactly look? As you can see, we have this dense capsule surrounding the entire lymph node. This capsule, which is basically a dense fibrous capsule, as we said, it will send down connective tissue strands that we call it trabeculae. So these are the trabeculae. So again, dense capsule sends connective tissue strands, and we call it trabeculae. The lymph node in general is divided into compartments because of this trabeculae. You can see you have this compartment here, this compartment, because of this extensions downwards. Now, one of the most important things about it, histologically, when you're looking at it under a microscope, it will present as two main parts, two distinct regions, a cortex, or the outer part, and the inner middle part called the medulla. The cortex can be seen as two collections, a superficial and a deeper part. Again, the lymph node has a capsule, a trabeculae, compartments. Then we have the cortex, and we have the inner medulla. The cortex itself divides into two main parts, or we can divide it into two main parts based on the components, a superficial and a deeper part. The superficial part, it will have lymphoid follicles, which, as we said, we previously mentioned, lymphoid tissue can present itself as diffuse lymphoid in some organs, or it can present as follicles or nodules. These nodules can present as separate isolated aggregates, like in the case of Peyer's patch in the appendix, or they can be present as part of an organ, like in the case of the lymph node. So in the superficial cortex of the lymph node, we will have lymphoid follicles, which is basically containing germinal center, and these germinal centers contain B cells. In the superficial part of the lymphoid lymph node. The deeper part of the cortex mainly will have T cells present, And these T cells, as we said again, they're going to continuously circulate, to continuously have surveillance, and so on and so forth. For the most part, we have dendritic cells present in abundance to be able to activate the T cells and the B cells, be them in the cortex, and so on and so forth. The inner part is called the medulla. This medulla, the most important thing about it, it has medullary cords, and with regards to its cellular components, it has both B and T cells. But the medullary part it has the medullary cords that makes it a little bit more distinguishable. So this is the general schematic of it. One more thing to mention before we mention tract or how does the lymph move, one more thing important to mention is the fact that we have something called sinuses, lymph sinuses. There are two main sinuses in the lymph node, subcapsular sinus and medullary sinus. These sinuses are nothing more than just lymphatic capillaries. They're large lymphatic capillaries, and on top of them they have crisscrossing reticular fibers. So they're lymphatic capillaries that have reticular fibers on them. These reticular fibers allow for macrophages to reside. So this allows for when we have the lymph entering inside, the subcapsular or the medullary sinus, they're lymphatic capillaries. So when the lymph is entering, the reticular fibers are situating on top of the capillaries, and they allow macrophages to basically get rid of these pathogens if present in the lymph node. So how exactly does the lymph pass or move inside? Is very simple. It will initially come from the concave part of the convex part, or this bigger kind of U-shaped part of the lymph node, and we call them the afferent lymphatic vessels. These will bring the lymph. Then this lymph will move into the subcapsular sinus, which is this sinus, which is, as the name suggests, below or under the capsule. So this is the capsule. So below the capsule, we have these lymphatic capillaries or the sinuses. We call them subcapsular sinuses. Then we will have smaller and smaller sinuses that will enter between the capsule to enter inside the medulla into the medullary sinus. So from the afferent vessels, they will enter. These afferent vessels enters the subcapsular sinuses into smaller sinuses to reach the medullary sinus. After that, they will leave. Obviously, as we said, the sinuses, they have reticular fibers. On top of them, we have macrophages and so on. So this entire process, we're cleansing the lymph and removing any pathogen. But for the most part, the way it leaves is through the afferent lymphatic vessels, which are present at the hilum. The hilum is this part here. It's this indentation on the concave side of the lymph node. We call it the hilum, and they leave through the afferent lymphatic vessels. So again, the general schematic of the lymph node, they are clusters that are present mainly around the lymphatic vessels. Mainly the most larger structures, or the largest clusters, are present around sites where we have the formation of the trunks. So they're inguinal, axillary, and cervical nodes. The lymph node mainly works to cleanse the lymph, as mentioned by the schematics. They will mainly pick up the lymph. When the lymph is going through the system, it will stop at the lymph node and stagnate, because one more thing to mention is the fact that there are more afferent lymphatic vessels than efferent. So there is more coming in, they stagnate a bit, and then they leave. So they will leave at a slower rate to allow the lymphocytes and to allow the macrophages to cleanse it properly. And also it's a site for lymphocyte activation or immune system activation. The APCs, the antigen presenting cells, اللي هم the dendritic cells and so on, they will come and present an antigen, be it to the B cell or to the T cell, to activate them and alert them to a pathogen. Then we spoke about the way that they move. We said that you have, or the histology first of all, we said we have a capsule. Capsule will send out indentation, we call them trabeculae, dividing them into compartments. We have the outer cortex and the inner medulla. The outer cortex has the superficial lymphoid follicle, which has the germinal centers and the B cells, and then the inner T cells. The medulla has both B and T cells, and for the most part, the most important thing about it is its medullary cord. And we mentioned the sinuses, which are basically just capillaries, lymphatic capillaries, with the reticular fibers and the macrophages residing on top of them. The way that the lymph is going to move, or the circulation in the lymph node, we will have the afferent fibers on the outer part of on the convex side of the lymph node. Then they'll enter through the subcapsular sinuses to smaller capsules to reach the medullary medullary sinuses. Then it will leave on the hilum, or this kind of indentation of the lymph node. It will leave through the afferent vessels to continue to the trunks and to the cords. So this is the lymph node, one of the most important organs in the lymphatics and in the immune system. The second organ that we'll talk about is the spleen. The spleen, one of the most important thing about it is that the fact that it's the largest lymphoid organ present. It is about the size of a fist. Its location is on the left side. Specifically, it is underneath or under the diaphragm, curling around the interior or the front aspect of the stomach. It has multiple different functions, from functions relating to the immune system, like lymphocyte proliferation, immune surveillance, and other functions relating to the blood, like blood cleansing functions, extraction of aged and defective cells, recycles some of the breakdown of RBCs. It's also very important the fact that it stores platelets and monocytes, and also the fact that in fetus it's considered as a site for erythrocytes to be produced. When it comes to its structures, similar to the lymph node, it does have a capsule, it does have a trabeculae, but something very important about it is the pulps, the white and the red pulp. The majority of the spleen is red pulp, and we have kind of clusters or kind of, let's say, like islands of white pulp present in the red pulp. The white pulp is the site where we have the immune function. The red pulp is the site for the RBCs and the blood cells and so on. So most of the time, this white pulp has lymphocytes. So even though it appears in a cross-section or it appears in a fresh spleen as white, under the microscope, it stains darker because of the nuclei of these lymphocytes. The red pulp has RBCs, worn out RBCs. It stores the monocytes, and it stores the platelets in this site and so on. So it's the site where we have the blood component of the spleen. So in general, the spleen is just a lymphocyte proliferation site, immune surveillance, and as we said, it's mainly constituted of the white and the red pulp, and their names are mainly talking about the way that they appear on a fresh spleen or fresh tissue, rather than the way that they would appear under the microscope, because white pulp would stain darker than the red pulp. Now coming to the homeostatic imbalances of both the lymph nodes and the spleen. The lymph nodes, sometimes it can get overwhelmed with the amount of agents or the amount of pathogens and the amount of bacteria and so on in it, that the lymph node itself becomes inflamed and becomes swollen. And we call this condition as lymphadenopathy. On the other hand, when a person has cancer, a lot of the time, if the cancer is metastatic, meaning the cancer or the cancer is malignant and it has the capability of metastasizing or spreading, basically, one of the secondary cancerous sites, or basically the site where the cancer can spread to, is the lymph node. So the lymph node can swell. So the whole idea of this homeostatic imbalance is to help you understand that lymphadenopathy is different from a cancerous infiltrated lymph node. They both appear as swelling of these lymph nodes or these clusters of these lymph nodes, but the main thing to differentiate between them is that lymphadenopathy, or the inflamed and infected lymph node, is going to be tender or painful to the touch, whereas the cancer infiltrated lymph node is not painful to the touch. This is with regards to the homeostatic imbalances about the lymph node. It can either be inflamed and infected and tender to the touch, and we call it lymphadenopathy, or it could be a secondary cancerous site where it's going to appear as a swelling of the lymph node, but it's not painful, and it is the way to distinguish it from the infected one. On the other hand, regarding the spleen does have a capsule, it does have trabeculae and so on, but the capsule of the spleen is quite thin. So any direct blow, any direct kind of impact on it can cause it to rupture. And because it's filled with a lot of blood, this can cause a lot of hemorrhage, and this can cause life-threatening hemorrhage and shock. So previously, it used to be treated by splenectomy, removal of the spleen. Surgically, they would remove the spleen. But it was discovered that these spleen actually can, basically, they heal on their own. So the spleen, it was discovered that they repair on themselves or alone, so they're left basically to treat them alone. But if in severe emergencies, if the spleen was to be removed, the liver and the bone marrow can take over the function. So this is the first two organs. We spoke about the lymph node and we spoke about the spleen. Now coming to these group of organs where we call them MALT or mucosa-associated lymphoid tissue, they're essentially a lymph tissues that are spread throughout the mucous membrane in our body. And the reason that they're spread all around is basically to just help the body against the infections and help the body against the constant pathogens that are present inside the body. They can be present in the digestive system, in the respiratory system, in genitourinary organs, and so on and so forth. And we'll see, mainly focusing on the digestive tract, we have tonsils, Peyer's patches, and appendix. The tonsils are these ring of lymphoid tissues that are present mainly at the opening of the throat, as evident by this picture here. So they're present at the opening of the pharynx, and they appear as the swellings of this mucous membrane or of the mucosa. So these tonsils come as different types, and they're named according to their location. We'll start off by looking at these palatine. These palatines are present in the posterior aspect of the oral cavity. They're the largest tonsils and the most infected tonsils. Again, palatine are paired, and they appear as basically these large swellings on the posterior aspect of the oral cavity, and they are very commonly infected. The other one that we have is lingual tonsils, as the name suggests, lingual, so in respect to the tongue, and they're present on the base of the tongue. Then we have the pharyngeal tonsils, which are basically present on the back or the posterior aspect of the nasopharynx. And when they're enlarged, we refer to them as adenoids. The last group of tonsils, or the last tonsils that we see, are the tubal tonsils, which are present up top, and they are basically alal openings of the auditory tubes. So tonsils are again these rounded or these ring-shaped lymph tissue that are present on the opening of the pharynx. They're palatine tonsils present on the posterior end of the oral cavity, very large and common to be infected or common to be enlarged. Then we have pharyngeal tonsils, which are present on the posterior aspect of the nasopharynx, and if enlarged, we call them adenoids, a very important point. The lingual tonsils are present on the base of the tongue, and the tubal tonsils are present on the openings of the auditory tubes. These tonsils, they are not very properly encapsulated, but something important about them is that they do have an invagination, which we call them tonsillar crypts. And the main point or the main function of these tonsillar crypts with tonsils is to trap bacteria, to help in producing memory and help in basically activating the adaptive immunity. The others that we have are pairs, patches, and appendix, which are very similar to each other in function. They will prevent bacteria from coming into the intestinal wall. They will generate memory and so on. The pairs patches are also referred to as aggregated lymphoid nodules that are present in the distal portion of the small intestine. So they're just aggregated lymph nodules. And finally, the appendix is just a tubular offshoot on the first part of the large intestine, as evident here. And again, their function is to help the immune system fight against bacteria and so on, and they are present in the intestine. The appendix is in the large intestine, and the pairs patches in the small intestine. This is everything with regards to the secondary lymphoid organs, the lymph nodes, the spleen, and the malt, the tonsils, pairs, patches, and the appendix. The last thing that will be mentioned with regards to this chapter is the thymus, which is a primary lymphoid organ, and it is essentially very important in the first years of life. It is present on the lower aspect of the neck up until upper aspect of the chest, and it's mainly overlying the heart deep to the sternum. The main function of it is the fact that it turns the lymphocytes. The lymphocytes are going to be formed in the red bone marrow. They will come to the thymus to basically become immunocompetent cells. In other words, the main job of the thymus is to allow these T cells to have the properties to defend us. Now, a very important function a very important factor about the thymus is there is no B cells at all present in it. There are no germinal centers. But the most important thing about the thymus is the fact that it has something called the blood-thymus barrier, where we don't want any pathogens to enter and any microorganisms to enter, because the T cells are still not at a stage to be activated. So the whole point of the thymus is I want these T cells to get mature enough to then go to the secondary lymphoid organs and get activated. But the thymus in itself shouldn't encounter pathogens. So it has a blood-thymus barrier. In general, this thymus, when a person is initially born, so as a newborn, this is where it's most active, highly large and so on. And as the person ages, specifically after puberty, it starts to atrophy and becomes replaced with fibrous and fatty tissue. It's still going to produce immunocompetent cells, but at a slower and a declining rate. The thymus, in its presentation, if we were to look at it, it has thymic lobules that do have a cortex and a medulla, so an outer and an inner part. The cortex, the outer part, will mainly have the lymphocytes, and the inner medulla, or the lighter stand, will have something called thymic corpuscles. These thymic corpuscles actually contain epithelial cells, which are specialized keratinized epithelial cells that are important in development of regulatory T cells. Regulatory T cells are a type of T cells that are mainly important in preventing autoimmune responses. So they don't work in activating the immune system, they work in inhibiting the immune system. So again, the thymus is essentially having these lobules and an outer cortex and an inner medulla. The cortex is mainly going to be produced by these lymphocytes, specifically obviously the T cells and not your B cells. B cells are not present at all in the thymus, so we will not see any lymphoid follicles or germinal centers in the thymus. The thymus will have the capsule, the cortex, and the medulla. Cortex will have the lymphocytes, and the inner medulla will have the thymic corpuscles, which will have the keratinized epithelial cells, mainly for the development of regulatory cells and so on. And as previously mentioned, all of our lymph nodes will contain the stroma of reticulars. It's a reticular stroma, except the thymus, which will have the epithelial cells that are very important in maintaining the environment of the thymus, unlike the other organs which will have the reticular stroma. This is just the general summary that's presented at the end of it. As you can tell, all of them will have reticular connective tissue as part of their stroma, except the thymus. As mentioned, all of them are going to have a capsule except the malt. We did mention that the tonsils have the very thin capsule. They're not fully encapsulated, but they have the tonsillar crypts. But again, in general, the malt or the mucosa-associated lymphoid tissues, they don't have a capsule. So, but again, you can mention something worth mentioning, that the tonsils are not fully, they have some level of encapsulation, but you can say that they're not actually capsulated. Cortex and medulla is only present in the lymph node and in the thymus. Then we said that the lymphoid follicles or the germinal centers are present in all of them except the thymus, because the thymus only has T cells. And then certain special features is the lymph node is the only one that will cleanse the lymph, so it has afferent and efferent lymphatic vessels. The spleen will have the red pulp for the bloods and all of the, the recycling aspects of it, and the white pulp for its immune surveillance and activation. The malt will have its diffuse lymphatic tissue and the follicles. And the thymus, as we said, it has the thymic corpuscles and so on and so forth, to allow it to have its functions of, activating T cells and so on and so forth. So this is in general the overview of what you would expect, or how, or the lymphoid organs and tissues. Now we're going to be covering the immune system. I'm going to be covering the first two parts, 21.1 and 21.2. And basically this will be covering mainly the innate part of the immune system. So as previously mentioned quite a few times, your immune system constitutes of two arms. The immune system, the main job of it is to provide the body with immunity, or the capability to fight against diseases and fight against pathogens. In general, innate and adaptive immunity. Innate immunity in itself has two lines of defense, the first and the second line, and adaptive immunity is the third line of defense. The main difference between the innate and adaptive immunity is the fact that the innate immunity is non-specific and usually is activated first, whereas the adaptive immunity normally is going to be activated by the innate immunity, needs more time to get activated, and is more specific. The first line of defense is your skin and the mucous membrane. And then the second line of defense, which both are going to fall under the innate immunity, is basically the cellular component and the chemical mediators. And the hallmark of it is inflammation, and we'll understand what exactly is inflammation and how does inflammation happen. So the immune system, even though they are technically separate systems, they do work with one another. They are going to work in synchronization. The innate is going to activate the adaptive immunity, so they are working technically together. They do release and recognize very similar molecules. Even though we said the innate immune response is not specific, it's not actually as non-specific as once thought. The way it works is quite similar every single time. And essentially, as I said, the immune, when it is going to get activated, it will release certain structures and certain mediators that will alert the adaptive immunity to work. The main job of the innate immunity is to provide the initial barrier so that the pathogens are not going to enter the body. And if they're breached, they will have their own means with dealing with it by the second line of defense. The third line of defense is activated آخر إشي, when basically the innate immune system cannot do anything alone, and it needs the support of the adaptive immune system of the lymphocytes, the T and B cells. It can't solely work, the innate system can't solely work alone. It can work alone as it is to fight and remove the pathogen. But as mentioned, if it's a severe infection or severe harm, then the adaptive arm will be activated. The innate immune system is born with at birth. You're born with everything at birth, unlike the adaptive immune system where things are going to get activated and so on. The innate immunity is born with at birth. So the innate, as we said, has two lines of defense. It has the first line and the second line. The first line of defense is essentially your intact skin and your mucous membrane. The intact skin is basically your highly keratinized epithelial layer that will provide a mechanical barrier to inhibit the entry of pathogens. Similarly, the mucous membrane is also going to be a mechanical barrier present at all of the openings of our body, so your digestive, respiratory, your urogenital systems, and so on. So both of them are going to work to prevent the entry of pathogens. When we're looking at the epidermis or your skin, it has keratin. It has this keratin layer, which is essentially it has the capability to resist acids, alkalines, and the enzymes of bacteria in general. The mucous membrane is, obviously, as we said, it's lining the outer layer, and it has the capability of, basically, it has mucus, or what we know as mucin, which is basically, it's mucin dissolved in water, gives us this thick, sticky structure that is present in the respiratory and this digestive tract that helps in trapping microorganisms. We have nasal hair as well that will trap microorganisms, the cilia that will propel the pathogens and so on from the lower respiratory tract upwards. Then we have the acidity in certain structures. We have the acid mantle of the skin. So the skin in general secretes certain secretions like sweat and sebum, which is the oil. And these are all in general acidic in pH, and this inhibits the growth of bacteria. We also have the acidic secretions in the stomach or the gastric juice, and we also have the acidic mantle of the vagina that, again, more or less all are going to inhibit the growth of bacteria. We also have certain enzymes like lysozymes, which are going to be present in the saliva, the respiratory mucus, and the lacrimal fluid of the eye that are basically going to destroy microorganisms. Again, pH of the urine also affects them. So in general, these are all more or less different factors. We also have defensin and dermicidine. They're all components that are going to be released by the intact skin and the mucous membrane to prevent the entry of microorganism and also to inhibit the growth or to destroy microorganisms, like in the case of the lacrimal secretions or the lysozymes. When it comes to the second line of defense, the second line of defense would be called upon or recruited, or it will work when the first line of defense is breached. If the skin, there's a cut wound or there is a certain opening in the skin that allows for the pathogen to enter, this will alert the second line of defense, and the second line of defense will come into play. This second line of defense, unlike your adaptive immunity, which relies mainly on antigens and on specific receptors, second line of defense mainly works via pattern recognition receptor. So it will recognize a certain shape or a certain pattern on this microorganism or on this pathogen and get activated, or not, they're always activated, but it will get alerted to fight against them. So these receptors, the most common type of pattern recognition receptors we have are called TLRs, or toll recognition receptors, or toll-like receptors, Again, there are different types of them. Some of them will work at recognizing the glycolipid part. Some of them will work to only work against a specific group of bacteria, like gram-negative bacteria and so on. But the whole idea is that they don't work by recognizing antigens. They work by recognizing a specific pattern in the pathogen or a specific shape via the pattern recognition receptor. These are the second line of defense, stems from different cells like natural killer cells and phagocytic cells like macrophages and neutrophils. And we also have proteins like antimicrobial proteins, اللي interference and complements. And the hallmark of it is inflammation, which is a localized response, and fever is your systematic response. So let's start by looking at phagocytes and these phagocytic cells and what exactly are they. Phagocytizing is basically the idea that this cell is capable of basically doing endocytosis and engulfing a specific pathogen and destroying that pathogen. Normally, this is done by neutrophils or macrophages. Neutrophils are the most common WBCs. They are quite important in phagocytizing, and they're the first ones to get called upon because macrophages are coming from monocytes. So monocytes are our WBCs, similar to neutrophils. Monocytes, when they leave and they enter the bloodstream, after a while they get activated and they become macrophages. So normally neutrophils are initially found, but macrophages are more potent and they're more ferocious, and they are the more phagocytic ones. Macrophages come in two different types. They're either free and roaming around, or they're fixed and they're called as stellate macrophages to a specific area, like in the liver and so on. They're permanent residents of a specific tissue. How do they work? How does phagocytizing work? Initially, what happens is these phagocytic cell, be it neutrophil, be it macrophages, and so on, they will basically have receptors on their extensions, on their parts here. They will have receptors, and they will bind or adhere to the pathogen. Then they will start to internalize the pathogen and form a phagosome. This phagosome will then fuse with a lysosome inside the cell, and it will form a phagolysosome. The way this phagocyte is going to kill is by acidifying this phagolysosome. So it will make it more acidic, and ultimately this destroys it. So again, phagocytes are cells that are present that constitute the second line of defense of our body. These cells can either be neutrophils or macrophages. Neutrophils are the most abundant WBCs, and macrophages are coming min monocytes. They're either free or fixed. The way that they work is by engulfing via the receptors. They engulf a pathogen. They engulf it based on a specific thing, based on a specific carbohydrate pattern on them. And then they will engulf it and take them in. When they take this pathogen inwards, they will fuse the phagosome with the lysosome and acidify the phagolysosome, and ultimately digest the contents and so on, and then get rid of the pathogen. So they destroy the pathogen by acidifying it. Certain microorganisms, basically what they do is they are resistant to acidity, like tuberculosis. It's resistant to the lysosomal enzyme and resistant to the acidity. So what happens, in order to get rid of them, the macrophages, what they do, or these cells in general, these phagocytic cells, they alert the helper T cells. So they activate the adaptive immunity. Helper T cells will start to release an interferon called interferon gamma, which we'll talk about later on, to further activate macrophages, and then it will get rid of this microorganism or this pathogen via something called as a respiratory burst, where we will have highly destructive free radicals, oxidizing chemicals, basically ultimately to further increase the pH and osmolarity and so on, basically working in a different way that's specific to that pathogen to get rid of it, because the simple acidification was not working in the case of مثلا tuberculosis. Other times phagocytes as well, they cannot engulf a certain pathogen because of, let's say, the size, it's too big. So what they do is they start to release their enzyme and their hydrolyzing enzyme to the outside environment to get rid of it. Now, sometimes there is a problem that arises with phagocytes because, as we said, the way that they work, the way that these phagocytes work is by, they have receptors on them, and they will recognize a certain carbohydrate signature or carbohydrate structure on them. Sometimes certain pathogens have a way or a means to basically hide from the immune system, let's say, and they conceal, they add a capsule on top of them, and they conceal their carbohydrate signature structure. So ultimately the phagocyte is blind to or incapable of recognizing this pathogen. So what happens, a means or a way for the immune system to fight against this specific pathogen is via something called opsonization. So certain structures like complements and antibodies released by the adaptive immunity B cells, they will opsonize, or they will add proteins. So they will add proteins on the surface of these pathogens to basically allow the phagocyte to have a handle to bind onto. So this is called opsonization. It's something done by both complements, which are antimicrobial proteins, and by antibodies released by the adaptive immunity, specifically the B cells. They will opsonize, or they will mark the cell or the pathogen to allow the phagocytes to recognize them, because as we said, they recognize them via a specific carbohydrate signature structure, and these pathogens have hid it. So in response, the immune system marks them again via opsonization. So this is everything with regards to phagocytes and the way that these phagocytes work, be them neutrophils or be them macrophages coming from monocytes. The other group of cells that we see are natural killer cells. Natural killer cells are actually granular lymphocytes, so they are technically lymphocytes, but they do not fall under the adaptive immunity because they're non-specific. They are far less specific, and they are going to be activated quite easily, unlike the adaptive immunity that needs APCs and so on. The way that these natural killer cells work is simply, on our cells, we have a certain cell surface protein called MHC, which will be explained more in the adaptive immunity. But it's major histocompatibility complex that is present on these cells, and they're present on our normal cells as well, not just pathogens. Certain cells, certain pathogens, and certain microorganisms lack MHCs. So when natural killer cells identify the lack of MHC, they will basically, they're not phagocytic, Unlike macrophages and neutrophils, they're not phagocytic. The way that they work is similar to the way that cytotoxic T cells work. They will cause the cell to undergo apoptosis, programmed cell death, but they kill the cell. Mainly, they affect cancer cells and virus-infected body cells. So virus and cancer cells, if they're lacking MHC on them, natural killer cell will force them to undergo apoptosis. But again, they're under the innate immunity, even though they work similar to the cytotoxic T cells, and even though they are technically lymphocytes, they're less picky, they don't need APCs, and so they fall under the innate immunity. Now let's look at inflammation. So we spoke about our cells, we spoke about the natural killer cells, and we spoke about the phagocytic cells, neutrophils, and macrophages. When it comes to inflammation, as mentioned, inflammation is the hallmark of your second line of defense, or the hallmark of even the innate immunity. It is a non-specific, localized response to a tissue injury. The tissue injury can be something like physical trauma, could be heat, could be chemicals, could be infection, a pathogen, and so on. And the whole point of it is to essentially to inhibit the spread of the pathogen. It will kind of border it around so that the pathogen doesn't spread to nearby tissue. It will remove the debris and the pathogen and so on. It will also work by releasing certain structures and certain mediators, chemical mediators, to alert the adaptive immunity, and it sets the stage for repair. When it comes to acute inflammation, so something that's happening on a short term, it has something called cardinal signs. Basically, when a person is undergoing inflammation, there are cardinal signs that are present. There are 4 main cardinal signs that are going to be explained exactly why they happen. There is heat, redness, swelling or edema, and pain. And sometimes people add, or it's added, there is also impaired function. But for the most part, inflammation is a non-specific, it's an innate response, it's non-specific, and it's also localized to a specific area due to a tissue injury, in basically hopes that it can get rid of that pathogen and alerts the adaptive immunity if it cannot. If it's acute, it will have heat, redness, swelling, and pain, and plus or minus impaired function. So let's start by looking at how the way that inflammation works. Inflammation is going to mainly be due to inflammatory chemical release, and then we will recruit upon certain cells in that area. So inflammatory chemical release is the idea that basically, be it injured cell, the cells that are actually harmed, or immune cells in that area, they start releasing chemical mediators. These chemical mediators, in turn, are going to work to recruit more cells to that area and to help in the healing process. So some of these chemical mediators include histamine. Histamine is basically going to be released by mast cells mainly and basophils. And the way that histamine works is it results in vasodilation and increased permeability. And we'll talk about this, why does it do that? But again, histamine, it's one of the most important regulators when it comes to it, when it comes to mechanical injury and so on. Released by mast cells and basophils, it will cause vasodilation and increased blood flow to that specific area. We also have kinases and prostaglandins that do work very similar to histamine, but kinases are actually plasma proteins. They also promote chemotaxis, which is basically recruiting these leukocytes and recruiting the blood cells to the damaged sites, and they also induce pain. But the more potent induction of pain is prostaglandin. Prostaglandin comes from a lipid called, or a fatty acid called arachidonic acid. They basically come from the phospholipids. We will have arachidonic acid coming from the phospholipid, and we get prostaglandins. Prostaglandins are basically, again, they are very similar to the way that histamine works. They'll do vasodilation, increase permeability, and so on. But one of their main functions is to induce pain. So a lot of the painkillers that are given, namely aspirin, works by inhibiting the release of prostaglandin. We also have complements and cytokines that will be discussed soon. But for the most part, it's the idea that inflammation is mainly regulated by these inflammatory chemical mediators that are going to be released either by the injured cell or by the immune cell, including histamine, kinases or bradykinins and so on, which are basically going to be cleaved to give us bradykinins, prostaglandins, complements, and cytokines that will do vasodilation, increase permeability, induce pain, and so on and so forth. So what is the point of vasodilation? What is the point of causing the blood vessels to become larger and to increase permeability? The reason for vasodilation is causing local hyperemia. What does local hyperemia mean? It's basically the idea that you need more blood flow to come to that site. More blood flows coming to that site, there's more cells, there's more white blood cells, there's more cells and chemicals that are ready to fight against this pathogen and remove that pathogen. But this hyperemia and vasodilation will result in redness and heat, 2 out of 4 of the cardinal signs that we've mentioned. Other than the vasodilation that is going to be induced by histamine and so on, we also have increased vascular permeability. This vascular permeability will result in the leakage of proteins, including clotting factors and so on, to reach and go into the interstitial site. This is going to cause edema. So now, normally, I don't have as much fluid, but because of the inflammation, because of the increase in permeability, fluid, including clotting factors, antibodies, and so on, are going to leave and accumulate in tissue spaces, causing edema. This fluid, because it's containing proteins in it, like clotting factors and antibodies and so on, is referred to as exudate. Now, when I have this edema, I have excess fluid, this will allow the lymphatic vessels to pick up this fluid and ultimately take it to the lymph node. Ultimately, this lymph node will then clean and cleanse, alert the body even more further than just the lymphocytes that are recruited to that area and bring upon more cells to that site. The clotting factors as well that have leaked can form a fibrin mesh that is going to basically isolate that area so that the pathogen doesn't spread even more. The last cardinal sign that we have to mention is pain. So we said we have redness, heat, edema or swelling, and pain. How does pain happen? Pain, as we mentioned, can happen because of the release of prostaglandin or kinins, but pain can also happen because of the swelling, compressing nerve endings. This will result in pain. So again, when I have histamine, I have the release of histamine and all of these chemical mediators, it will cause vasodilation. Blood vessels will increase in size. This will cause hyperemia, more blood coming to that site, more cells, more chemicals, redness and heat will result. This redness, these will also help in getting rid of the pathogen. Accompanying vasodilation, we have the increase in permeability. This will cause the fluid containing proteins to leave and go into the interstitial surrounding or the tissue spaces. And we call that exudate. The fluid, we call it exudate because it contains protein. And this accumulation of fluid is what we refer to as edema. Then what happens with the increased amount of the fluid, the increased amount of the protein-rich fluid? It will cause the lymphatic vessels to bring up more of that lymph up to the lymph node to further recruit and activate more cells. Then we also have the clotting factors that have left, which will act as a scaffold for repair. And as we said, the compression due to the fluid might result in pain or will result in pain. Other than that, we also need to recruit. So we said, we want to bring as many cells to that site as possible. So this will mainly happen via phagocyte mobilization because it's an acute inflammation. I don't want to alert any of my other cells. I don't want the lymphocytes to be recruited yet, even though we will initiate or we will inform the adaptive immunity. Initially, it will be dealt with by neutrophils and by macrophages. So this will happen via leukocytosis. Leukocytosis is the increase in neutrophils, the increase of white blood cells, which is a very important hallmark of inflammation or a very important characteristic of inflammation. We will have an increase of leukocytes in number due to leukocytosis inducing factors. So I'll have more neutrophils coming into that area, release of these factors and so on. By the injured cells, they will release leukocytosis inducing factors, and ultimately this will cause more cells to come to the injured site. Then we will have margination. These neutrophils will start to cling and stick to the walls of the capillaries and so on. We will have cell adhesion molecules that are going to sprout on the blood vessels, the capillaries and so on, and it will allow these cells to stick to them. Then we have diapedesis. Diapedesis is the idea that, or the fact that these cells, now that they have come, so we have leukocytosis, they increase in number, then they will come, then they'll start to stick to the blood vessels, to the endothelial wall of the blood vessel, then they will start to squeeze out of the blood vessels to go to the injured site. The squeezing out of the capillaries is what we refer to as diapedesis. Then they follow a chemotactic trail based on certain mediators being released, cytokines and chemokines, specifically chemokines. They will follow that trail to go to the injured site. So, neutrophils are initially what are going to be present for the first few hours. These neutrophils are going to be present. Then monocytes will come, but monocytes initially coming from the bone marrow aren't very potent and aren't very strong. So by the time, after a few hours, they change to macrophages, and macrophages are basically a lot more potent and a lot more ferocious and capable of removing the pathogen. And normally, predominating the end stage of acute inflammation are your macrophages to try and get rid of the pathogens. So this is the general schematic of tissue injury. As we said, tissue injury, again, when I have a tissue injury, be it because of a pathogen, could be because of a pathogen, could be because of a trauma, could be because of chemicals or whatever, this will result in inflammation. Acute inflammation is by these 4 hallmarks, cardinal signs: heat, redness, pain, and swelling. Normally what we see is the release of inflammatory chemicals from the injured cell or from the immune cells. They will release histamine, complements, kyanins, prostaglandins, and the like, and they will do vasodilation. Vasodilation will result in local hyperemia. Hyperemia, excess blood, will cause heat and redness. Sometime we'll talk about heat when we talk about fever and what the importance of fever is. This might increase the metabolic rate of cells, might help in healing and increasing healing and so on. Then, other than increasing the diameter of the cell or the vessels or causing vasodilation, we also have the increase in permeability. This will allow for fluid to leak out and we form exudate, which will explain pain and swelling. And also we said the idea that this will cause the fluid to basically be removed by the lymph node, and then the lymph node can then activate more cells. And also we said about the clotting factors and the fact that they will prevent the movement of the pathogen from going into the outer sites. And we also have the attraction of more cells, more lymphocytes. It could either be directly from the histamine or the complements and these mediators, or it could be from the leukocytosis inducing factors that is released by the damaged cell, which will cause increase in number of the cell. It will cause margination, it will cause diapedesis, and then it will cause the chemotactic tail to be formed. And this is the general idea of inflammation, the fact that I'm recruiting more cells, be it by the mediators, be it by the leukocytosis-inducing factors. I'm recruiting more cells to the damaged site to do more of the functions to help in removing the pathogen, and in turn there is the redness and the heat, the pain, the swelling, and sometimes even the limited range of motion to ultimately reach the stage of healing. Now, when it comes to inflammation, sometimes if it's a very severely infected area, you will have a mixture of dead or dying neutrophils, these cells that are going to basically accumulate tissues and dead cells and pathogens. They will accumulate and they form a pus. If it is not removed, or if the body cannot get rid of it, what happens is collagen will start to form, and ultimately this forms abscess. Abscess is a lot more severe, and abscess needs to be surgically drained. Now, we mentioned about tuberculosis. We said that sometimes tuberculosis has a means that it resists the acidification of the phagolysosome inside these phagocytes. So ultimately there's a respiratory burst because of the helper T cells activating macrophages. Tuberculosis in general, they have the means of hiding from the immune system and from even antibiotics and so on. When engulfed by the macrophages, they tend to hide inside the macrophages. They escape and they hide inside the macrophages. So we have the formation of something called the granuloma. It's almost like a tumor-like growth. And basically it's the idea that they will have a center. The center is going to be infected macrophages, a center of infected macrophages, and around it there are macrophages that are not infected. They're trying to kind of remove the pathogen. Normally, if a person has a granuloma, so there's a tuberculosis that is sitting, they might appear as asymptomatic, so there are no symptoms at all. But if the person is compromised, like for instance, a person becomes sick or their immune system weakens, this pathogen can then reactivate and it can basically cause an infection and cause a person to become sick. So in this homeostatic imbalance, we spoke about the pus formation, which is basically the dead, dying cells and so on. If it's not removed, it will form basically collagen fibers that are going to be laid down and forms abscess, which needs to be surgically drained and removed. And then we spoke about the formation of the granuloma with basically infected macrophages in the center and uninfected macrophages that can be activated if the immune system is weakened. Now we come towards the end. We're going to look at antimicrobial proteins that are mainly two groups, interferons and complements, and then towards the end, hopefully we'll talk about fever. Interferons are basically, again, they're antimicrobial proteins that are present to remove the pathogens, help in the innate immunity, and so on. When a cell is infected by a virus, viruses are acellular pathogens. They use the machinery of the cells to produce ATP and to do their functions and so on and so forth. Now, when a cell is infected by a virus, so a virus will enter the cell. When it's infected by a virus, that cell in itself cannot do anything. It's infected by a virus, it will be impacted by it. But what it can do is it can go and alert other cells via interference. So how can it do that? Basically, when the virus is infected, the interferon gene can get switched on, and then this will allow the interferon receptor to basically accommodate for the interferon to the nearby cells. Why? Why is it doing that? To basically tell the other cells to not synthesize any other proteins, degrade viral RNA, and so on. And because interferons are not specific to certain viruses, if a cell is specific, let's say host cell is affected by virus A and host cell B is affected by virus B, host cell 2 is affected by virus B, this basically, the idea is that even if it's releasing it because it's affected by a different virus, it's still going to protect it from the same virus because they're not specific to a specific virus. Interferons come in different types. You have interferon alpha, interferon beta, which basically have this viral effect. Interferon alpha and beta can also activate natural killer cells. And we also have interferon gamma, which is very important in activating macrophages. Because they activate macrophages and natural killer cells, and these cells are very important in helping with cancer and getting rid of cancerous cells, they do have an indirect role in fighting cancerous cells. Moving on to the second type of antimicrobial proteins, we have complement. It's a complement system, which is basically constituted of 20 plasma proteins that are going to be basically activated. They're normally circulating in the body, in the blood, in inactive forms, and basically they're activated by three main pathways, either by the classical pathway, which is via antibodies, or the lectin pathway via lectin, or spontaneously by the alternative pathway. Whatever the means of activation is, it will converge to give us C3. C3 will split into C3A and C3B. C3A is the one that will mainly help in inflammation, along with C5A. So C3A and C5A, they will mainly help in inflammation. They will release histamine, they will increase vascular permeability, and so on and so forth, to further enhance inflammation and the capability of the cell to fight against the pathogen. Whereas on the other hand, C3b will mainly help in opsonization, which was previously explained. Basically, we said that sometimes certain pathogens, what they do is they cover their carbohydrate signature or their carbohydrate structures that allows phagocytes to identify them. So antibodies and complements, specifically C3b, will cause opsonization. So they will mark the pathogen to enhance phagocytosis. Then we have C3b along with C5b. Mainly they do something, or they have membrane attack complexes. Put in simple words, basically these membrane attack complexes, they basically form pores and holes inside the pathogen, and water will start to influx inside the pathogen and ultimately cause it to lyse or die. So again, in the antimicrobial proteins is interferons and complements. Interferons is basically interferon alpha, interferon beta, interferon gamma that work in different ways by activating natural killer cells or by activating macrophages to help indirectly in cancer and or in viral infection, like in the case of interferon alpha and beta, where basically what they do, an infected cell will release interferons to alert the other cell to not produce any more proteins and to basically halt any functions that is going to happen. On the other hand, complements, which are basically a group of 20 proteins are activated by different pathways, are going to converge to give us C3, which will split to give C3A and C3B. C3A will mainly activate and enhance inflammation via histamine and so on. C3B will do opsonization, coating the pathogen for phagocytosis. And we also have C3B and C5B that is going to help in MAC or membrane attack complex to cause lysis of the cell. So we have inflammation, lysis, and opsonization. The last thing we'll talk about is fever. So when we mentioned inflammation, we said that inflammation is a localized response. Fever is a widespread response. It's something where the body it's more of a systematic response where the body has high temperature. Normally this is explained because foreign substances, macrophages and leukocytes and our defense cells, when there's a foreign substance, they start releasing pyrogens. Pyrogens are these chemicals or these structures in our body that will target the hypothalamus and the thermostat of our body to increase the body temperature. Now, the exact reason that fever happens isn't well understood, but for the most part, some of the explanations can stem from the fact that it can increase the function and the metabolic rate of the cells, ultimately increasing the repair, which is what we see in the cardinal signs of inflammation. We had heat, and heat increased metabolic rates, so ultimately can help in repair and in healing. And another explanation can be the fact that the excessive heat or the excessive fever affects the liver and the spleen, and it causes sequesterization or storage or hiding of the iron and the zinc. And iron and zinc are used by bacteria to grow. So ultimately sequestering them or hiding them can make them less available for the bacteria. So this is in general the innate immunity, constituting of its cellular component, اللي هم phagocytes, be it them neutrophils or macrophages, and the way that they work, from phagocyting, phagosome, phagolysosome, and then acidifying. We spoke about tuberculosis and the fact that sometimes we need the recruiting of other cells to help in the function of these macrophages, like in the case of helper T cells, releasing interferon gamma and so on. And then we also have neutrophils, which are also phagocytic cells, but they're just a little less potent than macrophages, and they're present more earlier on because macrophages are stemming from monocytes. We also spoke about natural killer cells, which are basically lymphocytes, but they're not specific, and they are they're going to activate, or they're going to kill based on the lack of the MHC complex, and this lack of MHC complex will cause the cell to basically work very similarly to the way that cytotoxic T cell works, and it will cause apoptosis. We also spoke about inflammation. We said that with inflammation, we have basically chemical mediators that are going to be released and the leukocytosis factors. Ultimately, the whole aim of this is to cause vasodilation, which will cause more blood to come to that site, carrying more cells, increase in permeability, which will ultimately cause the fluid to leak, causing edema, causing swelling. The fluid can go to the lymph node, activating more cells. Clotting factors can cause the preventing the pathogen from roaming around and going around and so on, and different factors ultimately all coming to the healing, and this is what's happening in acute inflammation. And then we also spoke about antimicrobial proteins, the interferons, and the complement system and the way that they work. Interferons, beta alpha, beta gamma, are going to work directly against viruses and indirectly against cancerous cells by basically activating macrophages. Interferon gamma and interferon alpha and beta can activate natural killer cells. Complements are mainly going to work. C3A is going to enhance inflammation along with C5A. C3B and C5B are going to have the MAC complex activated, and opsonization will be mainly by C3B. Which is, again, opsonization is the idea that you want to coat a certain pathogen to allow phagocytosis to happen. And then we spoke about fever, which is more of a systemic response to a pathogen or an abnormality in the body, where it can be explained by sequestration of iron and zinc, which will inhibit the growth of bacteria, or the increased metabolic rate can basically enhance the repair. And that's pretty much it from my part. Thank you so much.